Welcome, everyone. Thank you for joining us for today's session. We will wait a few minutes for everybody to get joined and then get started with the presentation today. If you want to, you can feel free to share where you're joining us from in the chat. We have someone from Saskatchewan, St. Hubert, Toronto. Welcome. If you're just joining us, we're just taking a moment to let everyone filter in, and then we'll get started with our session. And in the meantime, you can add where you're from in the chat. Okay, just in the interest of time, today is a bit of a shorter session, so we'll get right into it. Welcome, everyone. Thank you for joining us for today's workshop on understanding your pathology report. I am Rebecca Armstrong, the Director of Patient Education and Engagement with the Canadian Breast Cancer Network. This session is being recorded and will be available on our website for anyone who may have missed it, and I'll send out a link once the recording is available. You'll find previously recorded webinars that address a variety of different breast cancer related topics on our website. And if you haven't already done so, you can register for next week's session on deconstructing clinical trials. And we'll have a QR code at the very end of the presentation to be able to register for that one. I would like to extend our sincere appreciation to our sponsors for today's session who have provided support through unrestricted educational grants. Novartis, our gold level sponsor, Pfizer and Gilead, our silver level sponsors, and AstraZeneca, Merck, and Daiichi Sankyo, our bronze level sponsors. The format for today's session will be a presentation by our expert speaker, followed by a question and answer period. There will also be a few polls during the session, and if you've brought along your pathology report, have it handy to review alongside the presentation. Please feel free to submit your questions throughout the session using the Q&A function that you should be able to find at the bottom of your screen. And our speaker today will do his best to answer your questions, but please note that he may not be able to speak specifically to individual situations without having a complete medical history. I'd now like to welcome our host for today's session, Kathia Mendelea, Chair of the Board for the Canadian Breast Cancer Network.
Thank you, Rebecca. Welcome again, everyone. Thank you for joining us today. I am pleased to welcome and introduce our expert speaker, Dr. Jason Wasserman, a pathologist in the Department of Pathology and Laboratory Medicine at the Ottawa Hospital and an associate professor at the University of Ottawa. He completed medical school and residency training in anatomical pathology at the University of Ottawa before moving to Toronto to pursue a fellowship in head and neck pathology at the University Health Network. In 2018, Dr. Wasserman created mypathologyreport.ca, an online education tool designed to help patients read and understand their pathology reports. Since its inception, mypathologyreport.ca has been visited by more than 10 million patients worldwide. Dr. Wasserman, great to see you, and thank you for being here today.
Thank you very much for that introduction. I really appreciate that, and I appreciate the opportunity to speak to all of you today. It's a great chance as a pathologist to actually interact with patients as a pathologist. As we were discussing before the presentation, I am often in my office with slides, and it's really great to have that interaction with patients. So I'm going to bring up my presentation now. I am, as the introduction mentioned, a pathologist at the Ottawa Hospital. I'm specifically an ENT pathologist, so I'm not a breast pathologist. However, I have a real interest in patient education and helping patients understand their pathology report, which is why I started a website called mypathologyreport.ca. But I'm going to talk today about the elements of a pathology report and how you can better understand the common terms and phrases that we use so that you can play a more active role in your care. And I welcome any questions you have about the presentation. So let's start off with a couple poll questions just to get a sense of where the audience is at in terms of pathology reports. The first question is, have you received a pathology report? To date, have you received a pathology report? Give everyone maybe a minute to answer the question. And whenever we have enough responses, maybe we could put the responses on the screen.
Can everybody see those results?
I cannot see them where I am. Possibly I need to move this. Maybe you can just tell me the results.
Sure. So 95% of people said yes, they have received their pathology reports, and
Perfect.
5%, which is one participant, said no.
Okay, perfect. Right. So this is going to be a very knowledgeable audience. Everyone here has received a pathology report, knows what I'm talking about. Let's go on to poll question 2, which is, did you have an opportunity to discuss your pathology report with your doctor? Again, when we get all the results, if you wouldn't mind just letting me know what they are.
Absolutely. I'll give everyone a moment to fill it in, and then we will share them. Okay, I'll go ahead and share them now. So 67% said yes, they had the opportunity to discuss their pathology report with their doctor, and 33% said no.
Perfect. All right. And our third question then, on a scale of 1 being very difficult to 10 being very easy, how would you rate your ability to read and understand your pathology report? So this is a particular interest to me as someone who works on educational material for pathology reports. So how would you rate your ability to read and understand your report on a scale of 1 to 10?
Okay, I will go ahead and share that now.
Okay.
So I'll just run through quickly some of the numbers.
Sure.
We
Thank
have
you.
1 being very difficult, 9%. 2, 13%, 3, 17%, 4, 13%, 5, 9%, 7, 26%, and 8, 13%. And then there were
Okay.
no people who said 9 or 10.
All right. No one thought it was very easy, and it seems like the majority were on the side of the more difficult. All right. So that's not surprising. Often, patients do tell us that it's challenging to understand the pathology report, and especially some of the more technical details, which is why I'm really looking forward to talking to you today to try to help demystify some of the terms in your pathology report with specific focus on the kind of things you would see in a breast pathology report. So before we get into all that, just a general definition of a pathology report. So it's any medical document that's issued when a pathologist examines a tissue, It describes the tests that were performed, and it provides a diagnosis, which is basically a medical explanation for what they're seeing. And it's performed by a pathologist. So a pathologist is a medical doctor who specializes in the examination of tissues. And there's many different kinds of pathologists. I, for example, am an anatomical pathologist, and breast pathologists are also anatomical pathologists because they look at they look specifically at the breast. But other types of pathologists would be neuropathologists and hematopathologists. So when we look at the anatomy of a pathology report, although there is variation in the order and in the types of sections that you're going to get from one institution to another, the most pathology reports should have these components. The first, of course, is patient information, which is information about you at the top of the report, your name, your medical record number, any other unique identifiers, potentially your address. I would also have the name of your doctor often in there. It's also important that the site of the tissue is clearly identified. So in this case, when we're talking about breast biopsies and excisions, it would always be breast. Now, laterality is very important, and that would be in this tissue source or site. Clinical history. This is information provided by your doctor about your clinical history. So if you already have a clinical history of breast cancer and they're doing a repeat biopsy, a clinical history saying that you have breast cancer would be important. Then you have the diagnosis section of the report, which is the most important and what we're going to focus on for most of this presentation. The diagnosis section is the summary of the most important findings and really the take-home message for your report that your doctor needs to work with. Some pathology reports will include a microscopic description, depending on the pathologist. They might put this in a comment section, but some call it a microscopic description. If you're diagnosed with cancer and the cancer has been removed, you might have a synoptic report that is embedded within the microscopic description. And that basically provides a lot of the microscopic elements and the prognostic elements that your doctor will need to work with. And finally, you have the gross description, which comes after this information. And the gross description is a description of what the tissue looked like, the specimen looked like when it was examined without a microscope. So basically a naked eye examination of the tissue, providing information about the specimen that was provided. So I'm actually going to start with a little bit of information about the gross examination, because this is not something that patients often get to see or to hear about. But I think it's really important when we talk about pathology and pathology reports to understand where the material comes from that a pathologist examines. So when tissue is removed from a patient, be it a biopsy or, for example, in the case of the example I'm showing here, a mastectomy specimen, or a smaller specimen from the breast, like a lumpectomy specimen, it is first sent to the lab where it is examined by a group of professionals called pathologist assistants. And these professionals are specially trained to examine tissue and to identify the type of tissue, identify any lesions or any other abnormalities within the tissue, and then to act as the eyes for the pathologist, selecting areas of tissue that should be examined under the microscope. So when large pieces of tissue are removed, for example, a lumpectomy, the entire thing is not examined under the microscope. It would simply be impossible to examine all that. A pathologist assistant has to go through the tissue and identify the most relevant areas. Now, they do this using, one, their expertise and their knowledge, but also using protocols that are set up in the institution. In this image here, we can see one of our pathologist assistants at the Ottawa Hospital, Mary Cox, who's one of our most experienced pathologist assistants, and she's been doing this work for many years. In fact, I had the benefit of learning a lot of gross pathology from Mary when I was a trainee at this institution, and she's one of the many pathologist assistants we have here who play a really important part in the medical care provided to our patients. And so in this picture, we could see Mary examining tissue and then selecting certain areas that are put into these orange cassette blocks, which will then be made into slides. So I'm going to show another example of a different specimen. This is, again, from the breast. So the tissue is yellow in color, and that's because it's mostly adipose tissue or fat. But you can see that there is a white circular area, and I'm not sure if my mouse comes up on your screen, but there's a white area in the middle of the specimen and you can see it best in the upper row, in the third and fourth section. So there's a little white area there, and that's an abnormality. That's a lesion that's identified, and that was the reason that this tissue was removed. And so the PA would go through it and identify that area, and then take sections from that tissue to be submitted for microscopic examination by the pathologist. So in this case, I'm showing the map that the PA creates, showing essentially where they are sampling, so the pathologist knows exactly what they've taken. And in this case, they're going to be taking the abnormality in total, but they're also going to be taking additional areas which are the edge of the tissue and are called margins. And I'm going to talk about that a little bit more. And that's to allow the pathologist to see whether or not the abnormality extends to the cut edges of the tissue. And that'll be important, especially if it's a cancer. So this is the beginning of the journey for a tissue specimen when it comes to pathology. It comes to the lab and it gets examined by these skilled medical professionals who play a really important role in getting the tissue ready for the pathologist. The next most important thing to a patient, of course, is going to be the diagnosis section, and this is really where I want to break down most of this presentation to figure out what's in the diagnosis section. But basically, this is your summary or your explanation of the findings, and it's important to note that the information you find in your diagnosis section will vary based on what kind of procedure you've had, but also based on the institution. So I'm going to give an example here. On the left side, we see that there's an example biopsy report. And on the right side, we see an example for either an excision or resection report. So you'll notice that the biopsy report has the specimen site identified as the right breast. And it gives a diagnosis, in this case, invasive ductal carcinoma. But that's all they have in the diagnosis. After that, there's information in the comments section, which basically describes what was seen by the pathologist, mentions the grade, and says how it's a preliminary grade, and then mentions that biomarkers will be ordered. That's all we have in this biopsy report. It's a short report, basically just giving a diagnosis. And that is primarily primarily the purpose of a biopsy report, is to provide a diagnosis and to suggest any additional testing that might be performed. This differs from a report for an excision or a resection, where now it's the job of the pathologist to provide not only the diagnosis, and often the diagnosis is already established in a biopsy, but to confirm the diagnosis, and further to that, to then provide all of the important prognostic and predictive features that will help you and your doctor determine what is going to be the best course forward for your care. So in the case of breast cancer, the important things that our excision or resection report will be the grade, and often that's referred to as the Nottingham histologic grade. It will talk about residual cancer burden if you have had neoadjuvant therapy before the surgery was performed. It would talk about things like lymphovascular invasion, margins, and lymph nodes. And I'm going to go into all these things in more detail in the next couple minutes. But I just wanted to show you how the information really differs based on what kind of procedure was performed. So you're not going to get all that information on a biopsy because the pathologist simply does not have enough to work with yet to provide that information. So when we look at the individual components of the diagnosis section with breast cancer in mind, really the most important things are going to be the tumor size, the grade, the margins, lymphovascular invasion, residual cancer burden X, lymph nodes, and molecular markers. And I'm going to talk about specific molecular markers later on. This is all, of course, in addition to the actual diagnosis. So what the cancer is called. The tumor size, which will be reported anytime the tumor has been fully excised. So you will not see tumor size in a biopsy because the pathologist won't know how big it is yet. As long as there is tumor still present in the specimen, the pathologist will do their best, with of course the aid of the pathologist assistant who is examining the tissue, to determine the greatest dimension of the tumor. And this is important because the pathologic tumor stage is based on the tumor size. And prognosis, we know, is closely tied to the size of the tumor. So as tumors get larger, they are more likely to spread to lymph nodes or other parts of the body, and you may need additional treatment such as radiation or chemotherapy to deal with larger tumors. Now, when the PA examines the breast, they cannot distinguish between in situ, that is non-invasive cancer, and invasive cancer. So they're going to measure the whole thing. It is the pathologist's job to figure out the size of the invasive component after the fact, because it is only the invasive component that contributes to the overall tumor size and to the pathologic stage. And as I mentioned, the tumor size is important because it does determine the stage. And I'm just giving you, showing you a summary here of the most recent breast cancer staging. I won't go through all the details, but basically you can see that the bigger the tumor is, the higher the stage. And so the difference between T1, T2, and T3 are all tumor size. T4 is a little bit different because it involves other structures around the breast that might be involved. Grade is the next most important thing that you're going to find in your excision report. And grade is a term that pathologists use to basically describe the difference between the cancer cells and normal healthy cells that would be found in the breast. And a grading system has been determined to compare these two types of cells. The grade is important because it's a useful way of predicting how aggressive the cancer will behave over time. So lower grade tumors tend to behave in a more indolent fashion and not spread as frequently, whereas higher grade tumors are more likely to spread into surrounding tissues, but more importantly, to spread to lymph nodes. So the Nottingham histologic grade is the system that has been accepted by breast pathologists and oncologists in most Western and North American countries for grading breast cancer. And it's made up of three components. The three components are tubule formation, nuclear pleomorphism, and mitotic rate. And I'm going to show a picture of what these mean. But essentially, tubule formation is how closely the breast cancer cells are trying to recapitulate the little glands that are normally found in the breast. Nuclear pleomorphism is how much variation there is between individual cancer cells. If they all look wildly different from each other, we say there's a lot of nuclear pleomorphism. And mitotic rate is a description of how frequently the tumor cells are dividing. A mitotic figure is a cell that is in the process of dividing to create two new daughter cells. So finding more mitotic figures means that the tumor has a greater mitotic rate, and the tumor cells are dividing more frequently, which means it's growing faster and more likely to be aggressive. Here's a picture which kind of summarizes those things that I just described. So again, tubule formation, as you can see on the left-hand side of the screen, they're forming little round structures that are very similar in appearance to the normal glands of the breast. And if the majority of them are doing that, then you would give it a score of 1. So all these things are scored 1 through 3, I should mention. And so you give a score of 1. As it forms less and less tubules, it gets a higher score. Nuclear pleomorphism is similar. We compare the cells in the tumor to the normal breast cells. As they become more abnormal looking, we say that they have greater variation and more pleomorphism. Therefore, they get a higher score. And finally, mitotic activity. We have cutoffs of if it's 0 to 8, it would be considered a score of 1, 9 to 17, a score of 2, and greater than 18 or greater would be a score of 3. The pathologist then takes all three features and the score assigned to each and comes up with a total. And the total determines the overall grade of the tumor. So you have your low-grade tumors, your intermediate grade tumors, and your high-grade tumors, also known as grade 1, 2, and 3. And these are helpful because they give your doctor information about what we think this tumor is going to do over time. So a high-grade tumor, for example, is much more likely to spread to lymph nodes or other parts of the body than a low-grade tumor. So grade is very important. The next most important thing that you'll see in your report, and there's different ways of describing this, but they're called margins. A margin is the cut edge of tissue. So when a lumpectomy is performed, for example, the surgeon will attempt to take a rim of normal breast tissue around the tumor, and the area that they cut, so basically where the tissue that is being removed ends and the part that's left in your body begins, that edge is called a margin. A margin is important because it tells you whether or not the tumor was removed entirely or whether any of it was left behind. When a tumor is found at the margin may be described as positive. A margin that is free of tumor is often described as negative, but sometimes the pathologist would just say that the margins are free of tumor. And often in breast pathology reports, they like to provide the distance to the margins because that gives a certain reassurance to you and to your team of doctors of how far they were away from the cancer. So they usually like to leave a couple millimeters between the tumor and the margin just for safety, but that's not always possible. A negative margin, though, means that there's no tumor at the cut edge. Now, when pathologists assess breast specimens, they look for both invasive tumor at the margin and in situ or non-invasive tumor, which is often either called ductal carcinoma in situ or lobular carcinoma in situ. And they look to see whether or not those are at the margin, and those will be reported also if either of those are seen at the margin, because any of those could increase the chance for recurrence, but also they may be indications, depending on the rest of your clinical picture, for additional treatments such as radiation therapy to the site. I should also mention that margins are not reported after a biopsy because a biopsy, by definition, is not an attempt to remove the entire tumor. It is simply a sample of. So you will only see margins reported when the entire tumor has been removed or when a procedure was performed in an attempt to remove the entire tumor. Here's an example of what a margin would look like. This is an image drawn by a colleague and friend of mine, Dr. Zuzanna Gorski, who does a lot of great artwork for patients. And she's created this to show what it looks like when you have what a margin looks like, what a negative margin looks like, what a positive margin looks like, and why a positive margin might mean that tumor is left behind. So a positive margin is when basically tumor is right at the edge, and that suggests that some tumor would be still left over in the body. Lymphovascular invasion is something that is commonly described in breast pathology reports. Sometimes it's called lymphovascular invasion. Other times it's called lymphatic and vascular invasion. It means essentially the same thing. Blood vessels, as everyone knows, are thin channels that carry blood, whereas lymphatic vessels are smaller, thinner, and they carry a fluid called lymph. Lymph is a way of removing waste and transporting immune cells around the body. It moves from the body to the extremities, and it goes through lymph nodes. It's a drainage system, and it's important because cancers like to travel from the tumor through lymphatics to lymph nodes. So pathologists examine both lymphatics and blood vessels in and around a tumor to look for what is called lymphovascular invasion, which means the invasion of either of these structures by tumor cells. And here's a picture, again by Zuzanna, showing what this looks like. So on the top, you see a blood vessel, and then the blood vessel has been invaded by tumor cells, so it'll be vascular invasion. And below, you have a lymphatic vessel, which has been invaded by tumor also. Finding either one would be considered lymphovascular invasion. However, some pathology reports and some pathologists will break it up and say either there's lymphatic invasion or vascular invasion, depending on what they see. Lymphatic invasion usually means that there's a higher risk of going to a lymph node, whereas vascular invasion suggests that it's going to spread through the blood. And when it spreads through the blood, the typical targets are the lungs, the liver, or bones. Other sites, other organs can also be included, but those were the most important sites, and that's why lymphovascular invasion is an important risk factor when identified. So we talked a little bit about a lymph node. So what are lymph nodes? They are small bean-shaped structures that are part of the body's lymphatic system. They're a very important part of the immune system. Think of it as a meeting place for immune cells, where immune cells can share information about things that are going on in the body and organize the immune response to infections or other abnormal processes. And lymph nodes are commonly examined in patients who've been diagnosed with breast cancer because we want to see whether the breast cancer cells have spread to any of the nearby lymph nodes. So the first chain of lymph nodes is typically in the axilla. And so a variety of tests are performed to see if any of the axillary nodes are enlarged or whether there's any activity that might suggest that there would be tumor cells within the axillary lymph nodes. And the spread of cancer from the primary tumor, so the primary tumor in this case being the breast, to a lymph node is called a metastasis or a lymph node metastasis. So here's an example of what a lymph node would look like. It's a small bean-shaped structure. It has blood vessels and lymphatic channels going in and out of it. The lymphatic channels go in, the blood vessels come out. The cancer cells can travel to these lymph nodes through lymphatics that are also in the tissues. And then they can spread from one lymph node to the other through the lymphatic system. When we talk about lymph node metastases, we often talk about the size of the deposit within a lymph node. So a deposit is a group of tumor cells, and it is important for breast cancer that the size of the deposit within the lymph node, the size is reported, because it affects the nodal stage. So for example, you'll see phrases in your pathology report, such as isolated tumor cells, micrometastases, or macrometastases. An isolated tumor cell is a small group of cells that measures less than 0.2 of a millimeter, so very small. A micrometastasis is a group measuring between 0.2 millimeters and 2 millimeters. And then you have a macrometastasis, which is one that's greater than 2. Micro and macro are often fairly easy for a pathologist to see on just what's called a routine hematoxylin and eosin stain slide. However, isolated tumor cells sometimes need to be identified through immunohistochemistry, but that's not routinely done in all institutions. They can, though, be spread out throughout the lymph node, which makes them a little bit more difficult to see. And I'm going to show you how this affects the staging of breast cancer in 1 second. So when there are no cancer cells found on any of the lymph nodes examined, it's called N0. If, though, only isolated tumor cells are found, it is still considered N0, but it has this qualifier of I+ to show that isolated tumor cells were found. Why is it given an N0? It's because the data has shown that these behave closer to negative lymph nodes than they do to positive lymph nodes, but it's still documented for accuracy. Then you get into the micro and macro metastases and the number of lymph nodes. So the difference between N1 and N2 depends mostly on the number of lymph nodes that are positive and the size of the deposit in the lymph node. When you get into N3, you're talking about lymph nodes that are outside of the axilla, and it doesn't really matter at that point how big the deposit is, as long as they're outside of the axilla. You get into N3 disease. Another important feature that you will see in your report, if you have had neoadjuvant therapy prior to surgery, is the residual cancer burden index. This is something that was developed by the physicians at MD Anderson Cancer Center in Texas, and it's basically a way of calculating how much cancer is left after neoadjuvant therapy, and then coming up with a score that helps categorize patients into risk and how likely they are to do well or to do worse after the specimen has been excised. So a variety of pathological features are combined to a single score, and then the patients are classified. The 4 features that pathologists look for are the size of the tumor in the breast. And so this is taken usually on the gross examination, as I mentioned, by the pathologist assistant. And so it's in the largest 2 dimensions of the tumor. And this is what we also call the tumor bed. This can have normal tissue cancer cells and scar, and scar rises secondary to therapy. Then the pathologist looks at the cellularity. So that is basically the number of cells in a certain defined space, and they classify it by the level of cellularity. They then look at the percentage of in situ disease, and this is important because in situ disease is non-invasive cancer, and so it's less likely to harbor a bad outcome if there's more in situ disease. So when they look within the tumor bed, they will measure the amount that's in situ and the amount that's invasive. Having a greater amount of invasive disease after therapy is worse than having more in situ disease. However, having in situ disease after therapy still suggests that there could be a recurrence, a local recurrence in the breast, and your doctor will probably talk to you about the kind of follow-up you might need because of that. Finally, we have lymph node involvement. So cancer within a lymph node is taken into account for this score because it is assumed that the therapy treated all sites and not just the breast. Using that information, patients are divided into 4 categories, ranging from RCB 0, which is a complete response. So that essentially means that no invasive cancer is found in the breast after therapy, to an RCB 3, which means there's still a large amount of invasive cancer within the breast or the lymph node. So obviously, the outcome that everyone would like is to be an RCB 0, which means that the cancer responded very well to neoadjuvant therapy. Next, I mentioned earlier on molecular markers, and so I'm going to talk about those now. The most common molecular markers that are assessed in patients diagnosed with breast cancer would be your hormone receptors, estrogen and progesterone receptor, and HER2. First, looking at the hormone receptors, these are special proteins that are found on the surface of cells. They're also can be found on the inside of the cells, so either in the membrane or in the nucleus. They act as locks, essentially, and specific hormones unlock them. So estrogen would act on the estrogen receptor, and progesterone would act on the progesterone receptor. When it binds, it sends signals through the cell that tells the cell to do certain things, such as grow, divide, or produce other substances. This is important because breast cancer cells that express estrogen or progesterone essentially can be turned on and off by the presence or absence of these hormones. So an estrogen expressing tumor will be stimulated to grow and to divide by the presence of estrogen, whereas an estrogen, a tumor cell that does not express the estrogen receptor will be insensitive or will not respond to estrogen. Pathologists test for hormone receptors using a test called immunohistochemistry. Immunohistochemistry essentially allows pathologists to see proteins expressed on certain types of cells by having the cells change color under the microscope if they are expressing those cells. After immunohistochemistry is performed, the pathologist examines the slide under the microscope and looks for 3 things when assessing estrogen and progesterone receptors. One is the percentage of cells that are positive. When we talk about these 2 hormones, we talk about nuclear positivity, which means the expression of these receptors in the nucleus, the area of the cell that contains the genetic material. So we're talking about nuclear reactivity. So the percentage of cells that have expression in the nucleus would be reported. Anything greater than anything at 1% or greater is considered positive, a real result. We also look at the intensity of staining. And this is a little bit more subjective, but pathologists do have good criteria that they use, well-defined parameters for determining the intensity. And they basically look at how strong it is within the nucleus. Is it weak? Is it moderate? Is it strong? And this is a reflection of the number of receptors essentially that are present in the nucleus. So a cell that is very, very intensely positive for an estrogen receptor will have a lot of estrogen receptors and is more likely to respond very strongly to estrogen hormone. Finally, they give an interpretation. So a positive result, when, for example, if a pathology report says estrogen receptor positive, that means that 1% or more of the tumor cells have shown nuclear reactivity. The guidelines have recently been revised to say that anything from 1 to 10% should be for estrogen should be reported as low positive, because they may signal a slightly different response to therapy. However, anything at 1 or over 1 is considered a positive result. So that may seem surprising that even having such a small number of cells considered positive, but studies have shown that even with a small number of reactive cells, the tumor still does seem to respond to hormone. So this will be reported for both estrogen and progesterone. And often it's reported on the biopsy result, on the biopsy report that is issued. However, it can be performed on the excision or resection if it wasn't performed on the biopsy, and sometimes it is repeated on the subsequent excision or resection if the pathologist feels that potentially the initial biopsy was not representative. But what does that mean? If the pathologist does not feel that the tumor sample in the biopsy really reflected what was going on in the full tumor that they're seeing when it was removed, they might order it again just to make sure they have a complete picture of this tumor. HER2 is the other molecular marker that's often ordered. And HER2 stands for human epidermal growth factor, growth factor 2, receptor 2, sorry. It is a gene that helps control how cells grow and divide. So it's similar in a way to estrogen and progesterone receptors. It's part of a family of proteins that exist on the surface of a cell. So when pathologists assess HER2, they're not looking at it in the nucleus. They're looking at it on the surface of a cell, which is called the membrane of the cell. And normal cells will express HER2. HER2 is not an abnormal protein. HER2 is not a cancer protein. It is something that is normally expressed in small amounts on many normal cells. However, there are certain types of cancers that will upregulate their HER2 expression because they have duplicates or more than 2 copies of the HER2 gene. So when you have more than 2 copies of the HER2 gene, we all have 2 copies of each gene, but when you have more than 2 copies of a gene, you could at that point start producing more copies of the protein, which would allow the cell to respond more strongly to that particular protein. In this case, HER2 is the protein, and a cell that has more than 2 copies of HER2 could respond more strongly. Thereby, it could grow faster and divide faster than normal cells. 2 tests are performed by pathologists to look for HER2. The first is called immunohistochemistry, and the second is fluorescence in situ hybridization. They're slightly different. Immunohistochemistry is the same as I described before for ER and PR. And basically it lights up the protein on the cell and allows the pathologist to see it under the microscope. It is scored from 0 to 3. 0 and 1 plus are both considered essentially to be a negative result. And that means that either no cells are expressing HER2 or that it's very faint and in less than 10% of cells. 2 plus is considered an equivocal result. An equivocal result is important because they usually will go on then to FISH testing as a tiebreaker, essentially, to determine whether or not it really is overexpressing HER2. And then finally, you have the 3 plus, which means that the cancer cells have a high level of HER2 expression by immunohistochemistry, and you don't need to go on to FISH. You can simply call that one positive because they are expressing it. When you do FISH, they look at both the number of copies and the ratio of the gene relative to another housekeeping or baseline gene that is expected to only have 2 copies. And so you want to look at the ratio because some cells will duplicate all of their DNA. So having more than 2 copies of HER2 doesn't necessarily mean that it's specifically increasing its HER2. It may be increasing all of its DNA. So you look at the ratio relative to other genes, but you also look at the number of HER2 copies. If you have more than the normal number of HER2 copies, and the breast pathologists have their guidelines for this specific test, then you could call the result positive. If it has no amplification, then you would call it negative. So a 2 plus with a negative for FISH, it would be negative. A 2 plus with a positive would then become positive. But you don't need to do FISH if you have a 0, 1 plus, or if you have a 3 plus, because those are considered definitive answers. Now, some institutions perform immunohistochemistry and fluorescence in situ hybridization at the same time. They do both because they want to look at them together. Most institutions, however, will do immunohistochemistry first and then move on to fluorescence in situ hybridization if needed. I'm going to show some examples here just to give you a sense of what this looks like, both to give you a sense of what immunohistochemistry looks like, but also to allow you to see what HER2 actually looks like. So at the top on the left-hand side, you can see a 1 plus HER2, which is basically a small number of cells that are weakly positive. And now you see, I know for those who've not, looked at these before, it's difficult to interpret what we're looking at, but you could see some blue circles, and those are the little blue circles are the nuclei, so the nucleus of the cell. And then you have the little brown rim around some of the cells. So you look at those thin brown lines. That is the membrane of the cell being highlighted by the HER2 antibody. So in this case of the 1 plus, the cells do not have complete membranous staining. It's only staining part of the membrane, and it's weak and less than 10% of the cells. In the second example, the 2 plus, it's more than 10% of the cells, but it's not complete around all the cells, and it's somewhat weak still. And how do we know it's weak? Well, if you look at the one at the bottom, which is considered a 3 plus, that is considered a strong complete membranous reaction. You can see that it's much, much easier to see the brown staining. So the brown is the HER2. The cells that have brown are overexpressing HER2. So the bottom would be a HER2 positive tumor, whereas the top left will be a HER2 negative, and the top right will be an equivocal that would have gone to FISH. So that not only gives you an example of what immunohistochemistry looks like, but that also shows you what the pathologist is interpreting when they look at a HER2 sample. So at that point, this is when I've gone through the majority of the features that one would see in a typical pathology report. Now, there is a lot of variation from institution to institution, and so some of you may have seen some other things. And the order that things are reported is going to vary, of course, between institutions. But I've tried to touch on the most important things that are in most reports. At this point, I would be happy to take any questions that you may have about the slides that I've presented, about the information I've talked about here so far, or any questions you have. Now, keep in mind again that I don't have your medical information, so I really can't answer too much about your specific situation. However, if you have questions, of course, about the terms in your report or what something means, I would be more than happy to discuss that with you. Also, I want to point out that if you ever do have any questions of your report, or anyone you know has questions about the report, we've created this resource called mypathologyreport.ca, where you can go and learn about hundreds of different common pathology terms and see many more great images drawn by Dr. Zuzana Gorski to help patients understand the report. So at this point, I will stop my presentation. I thank you for your attention. I would be happy to answer any questions you have.
Thank you so much. This was incredibly interesting, and it really does answer a lot of questions, I'm sure, to a lot of patients. I'm going to start by asking you just a couple of questions, and then I'm going to read off some questions that have been submitted. So in the overall way of determining, the diagnosis, you determine the course of treatment by your pathology report, and then together with the physician's clinical assessment, and they also determine the prognosis of a patient. How has changed over the years? Because in a couple of your slides, you mentioned that we no longer determine it by less than one and more than two. So how have things changed over the years, and how has that impacted treatment for patients based on that?
Yeah, that's a great question. Pathology reports have become a lot more complex over time, and I apologize. I see for some reason I am but a shadow of myself. I'm not sure what's happening with my camera here. It looks like I'm sitting in the dark. I am actually not sitting in the dark. I am sitting in the light. I just don't know what's wrong with my camera, so I don't want people to think that I just sit here in the dark all day. But the pathology reports used to be very short and simple, and they basically were a histologic description. So histologic being what the pathologist saw under the microscope when they looked at the hematoxylin and the eosin. So that pink and purple image that probably people have seen, when they just do a search for pathology on the internet, or they may remember from science class years ago. Pathology used to look at that and say, okay, it's invasive ductal carcinoma, it's this big, it's involving these margins, and it's done. That was the report. It was very short. Now, the bulk of the work done by pathologists is to look for all those other prognostic features that we know are important for driving the response to therapy, but also they give information to the how likely a person is to develop metastatic disease and how likely they are to respond to treatment. So molecular markers would be the biggest non-histological part of a pathology report at this point. And looking at estrogen, progesterone, HER2, in other centers in the United States in particular, they do a wider molecular panel where they're going to be looking for a variety of other genes. That's what people refer to as, the personalized medicine side, when you start looking at the large groups of genes that might be involved in the cancer. However, the core molecular markers, estrogen, progesterone, HER2, take up a large amount of the time. And that's because assessing these markers is time consuming. It's not straightforward. Often you can get to the diagnosis pretty quickly, but actually doing the assessment of HER2, estrogen, progesterone takes a lot of time. The description of these results also is a good chunk of the pathology report. And for what we saw from the earlier poll results, that most people have received the pathology report before. And often patients that I've talked to have said that the most difficult thing to interpret as a patient is that molecular report that comes out afterwards, that basically talks about the tests that were done, talks about the intensity, talks about the percentages, and gives a final interpretation. Those things are very challenging. So pathologists have really moved from being what we call histopathologists, ones who look at just the morphology, what cells look like under the microscope, to now truly diagnostic and molecular pathologists who are incorporating the genetic and the appearance of the tumor cells into a report. So that's been the biggest change.
Okay, great. Thank
And
you.
sorry, Kathy, just before I just want to jump in real quick just to mention that we are a little bit over time, but if anybody who's watching is not able to stick around for the few minutes for the Q&A, they will be part of the recorded session, and I'll make sure to send that out.
Thanks.
Go ahead,
Thanks,
Kathy.
Rebecca. So one thing that I was finding I missed hearing is luminal A and B. Is that something that is still looked at in terms of being able to determine how a patient is going to be treated?
That really depends. That's an institution by institution thing. So there's breast cancer research is one of the biggest areas of in terms of overall oncology research, and there's a tremendous amount of work that's been done, and that came out in the research literature years ago. How you could take these genetic signatures and start grouping patients into luminal A, luminal B, and other smaller categories. And there are institutions in the States that will do the full molecular panel and will provide that diagnosis. We don't do that here routinely in Ottawa, where I am, and most Canadian centers will not report that. And the reason for that is not that it's not important; it's just that it overlaps significantly with the known histological and the other molecular markers such as estrogen and progesterone and HER2. So not every center has access to these tests to be able to provide a luminal A or B category, but also it simply does not add enough for many centers. Now, again, it depends on what kind of therapy is being offered. In a clinical trial, you might need to know that. So in the United States, for example, they often will do these tests when they enroll someone in a clinical trial. However, for routine day-to-day treatment here, especially in Canada, those will not be reported. The pathologists are aware of them. The research in that area is still very good, except it overlaps a lot with what is already being done in terms of just the standard molecular markers, and so it's not reported separately in most places.
Okay, thank you. Needle biopsy, is that what you refer to when you say biopsy versus incision and then pathology afterwards? Now, with the needle biopsy, if a tumor is very small, is there a possibility that that needle biopsy may not actually get into a malignant cell to report it as positive?
Yes, great question. So when I refer to a needle biopsy, there's two kinds. You can have a core needle biopsy, which is a thicker needle that is put into tissue and a core of tissue is taken out. So it's like a little tube of tissue that gets taken out, and it's within the inside of the needle barrel, and it's looked at by a pathologist, and it's a thin strip of tissue. Then you have a fine needle aspiration, which essentially puts in a thinner needle, sucks out tissue, and then that tissue gets separated and is examined as scattered cells. It's not whole tissue anymore. Most of the time, patients here in Canada are diagnosed on core needle biopsies. In the States, they do it in a lot more fine needle aspirations. Here, we do a lot more cores because we get them done fast enough. And to your second question, can you miss a small tumor? Absolutely. So one thing we always say in pathology is that we can only diagnose what's on the microscope. We cannot necessarily diagnose the entire patient. So it's very important for pathologists to correlate what they're seeing with the clinical information. So a patient who has a mass in the breast and the pathologist looks at the core needle biopsy and sees nothing, it's normal. The pathologist has a responsibility there to say in the report, this is likely not representative of the mass that was seen, because maybe the mass is small and was missed, or the mass is big enough, but just it was not picked up in the tissue. Because what you don't want is you don't want a patient getting a report that says negative, you're cancer free, but in reality, what happened was the needle simply missed the cancer. So yes, it is possible, and pathologists and surgeons and others have to work closely together to make sure. But this is where patient education is so important, because patients reading their report, seeing that the pathologist has clearly said this may not be representative, a repeat biopsy is advised. A patient reading that will then be able to go back to their doctor and say, I'm worried about what this pathologist said. I think that it was missed. This wouldn't have happened 10 years ago before patients saw the reports.
Okay. Thank you. I have one more question to ask of you. When the patient receives these reports, if they want to receive them, some patients don't, some patients do. Of course, it's very, very hard to understand it. We can understand it because we work in this, but a newly diagnosed patient, there's a lot of information. And your website offered so much explanation to patients, obviously, because it's very well, looked into. My question is there a thought around simplifying a report by the pathology department so that they get both the full, assessment from pathologists and their team, and then a simplified version so that the patient could actually look at it and then use it to go back and forth with the full report?
Yeah, that's a great question, and it's something that's being examined now. A number of research papers have come out in the last couple of years looking at exactly that. These patient-friendly pathology reports, essentially a summary for the patient, and that's a great idea, and it would be very helpful. I'll be honest with you, uptake for that is going to be tricky, because you have to get buy-in from all the different centers. We don't centralize anything. And you have to get every pathologist to buy into it. Then you have to get all the centers to buy into it. And then you actually have to be able to figure out how to write a good patient-friendly summary. And as someone who spent several years trying to figure out how to describe some of these words in patient-friendly terms, it's not always easy. So, saying, when it's a straightforward diagnosis of invasive ductal carcinoma, you could say this is a type of breast cancer. The problem is when you start to get into borderline diagnoses. The pathologist is not exactly sure if this is cancer or if this is not. They're not sure if there's any residual disease or there's not. That's when you start getting into a lot of terms that are very difficult to put into a patient-friendly report.
Yes.
And so, in that case, pathologists are more hesitant to write a patient-friendly report because they're not even sure how to say it in a patient-friendly way. This is something where I think artificial intelligence could potentially help by providing a little bit of that, and having something built into our reporting system that can generate it. But it also can be wrong. I've asked it to try to generate these, and it's right for the first half, and then it goes into wild stuff that is not even close. And so we have to be very careful with how we generate. But I agree, that's a great idea.
Yeah, and if ever there's a thought around that, you should always include a patient with the lived experience to sit around these discussions.
And we do for my pathology report. It's exactly, we have a patient advocacy group that reviews all of our articles for exactly that reason.
Yeah, exactly. So I'm going to move on to people that submitted questions because I could take up all of your time forever and ever. So one of the questions that was submitted was, can a PET scan identify spread to axillary lymph nodes?
Yes, PET scan. Now I'm not a radiologist, so I won't get too far into this because I'm going to be out of my area of expertise. But a PET scan certainly can. A PET scan is designed to pick up increased metabolic activity or activity by other specific markers that can be identified by the machine. And if a lymph node is what's considered hot, so it's metabolically active because there are cells there that are more metabolically active, then it can pick it up. The thing about most cancers is that they tend to use more calories than normal cells because they're dividing and growing faster. So that's why they can be picked up by modalities such as PET.
And I'm going to ask one last question. I apologize to everybody because this was so interesting. But before we end this session, the second question is, how is RCB measured after treatment and pre-surgery?
So I had that on my previous slide, and I could bring it back up if people would like. But essentially, because I know actually, before I answer the question, I just want to say for anyone who's online who didn't get their question answered, there's an email address on the website. You can also email us at. I'm happy to respond to your emails through there. So obviously the organization could send me things and I'm more than happy to respond. But if you go to the website, go and email info or use our contact page, please send us an email. I usually get them and I'm happy to respond to anyone's questions. So RCB, again, you have to first identify where the tumor was. So the patient's had chemotherapy or radiation. The specimen gets removed. The pathologist assistant carefully examines the tissue, finds an area that's usually firmer, more dense, usually a little more white than the rest of the surrounding breast tissue, which is often fatty, and they sample that area generously, which means they remove it and put it in the little cassettes to be examined by the pathologist. They measure that area, and then the pathologist looks at it carefully to find living tumor cells. When the pathologist identifies cancer cells within that area, or at the very least the tumor bed, then they do the calculation, which I mentioned earlier, which was they look at the size of the tumor bed, they look at the approximate cellularity of the tumor bed, so how many cells are in there, how much of it's invasive versus in situ, so non-invasive, and then finally whether or not any of the lymph nodes are involved by cancer. So you take those together, and then you go onto the MD Anderson website where they have the RCB calculator. You input those features into the calculator, and then it gives you an index score essentially, and then that is what's reported. So RCB 0 through 3 would be reported.
Wow. Before we end, and I always hate ending on a high note because it seems like an abrupt finish, but we must do what we must do. Why only MD Anderson? Are they the only ones that have the index?
They created it. They
Oh, they
created. I mean,
created.
I suppose anyone could put their calculator on their website, but it would be wrong to take away credit from them. They came up with it. They have a nice index that everyone can use. So yeah, that's where the pathologist will go to do that.
Okay.
I apologize that I realized I went over a little bit in time in my talk and didn't give as much time for questions, but thank you everyone for.
I think both you and I went over time. I could ask more questions. So I'm just going to conclude and say this is it for the time we have today for our session. I want to thank you everyone for your questions, and please submit them if you have not, been able to have your questions answered. Thank you for joining us. It was a pleasure to have you, Dr. To me, this could go on forever. So if Dr. Wasserman, would like to come back, maybe we'll invite you to.
I'm happy to come back. I went over time, so I'm happy to come back and we can talk about another topic next time.
Good. We can plan that. So thank you again to our sponsors, Novartis, Pfizer, Gilead, AstraZeneca, Merck, and Daiichi Sankyo. Following this session, you will get a link to complete a survey to provide feedback on the session. Please consider leaving feedback, as this really helps us to improve future sessions for attendees like yourself. And if you haven't already done so, there is still time to register for next week's webinar, a workshop on deconstructing clinical trials. In this session, a medical oncologist will explain key terms found in clinical trials and research study results to help you better interpret the important advances in breast cancer care. Use the QR code on the screen to register. And with that, have a wonderful afternoon. And thank you again, Dr. Wasserman. This has been a great pleasure to have you present this to us today. Thank you, Rebecca.
Thank you, everyone.
Thank you.